Fantastic. So we're now going to start. I'd like to welcome all participants who've joined us today for the Pre-WHA press briefing. Teams across the world in different countries, member states, delegates are all gearing up for this week's World Health Assembly. So welcome to this press briefing. We do have a set of revered public health experts who will be joining us today to share with us Africa's positioning for this 77th World Health Assembly. And so this should be an exciting 1 hour, and very excited to see people coming in. We are now at 141 participants, and we welcome you all. And so getting into it, the 77th World Health Assembly is set to begin on the 27th of May, running all the way to the 1st of June. And as we all know, WHO brings together 194 member states in a participatory governance process that culminates in the World Health Assembly every year. The World Health Assembly, in essence, is the decision-making body for WHO. It determines the policies of WHO. It supervises the finances of WHO. It supervises the program-based budget. And it's essentially a coming together of these member states to determine global health policy. The executive board has finalized this year's agenda, and I'd encourage all of you to get onto the WHO website and look at the agenda for this year's World Health Assembly. A lot of very key pertinent discussions will be held, particularly when it comes to global public priorities, public health priorities. There'll be sessions that will take stock of successes and milestones that have been made. There'll be sessions that will be advocacy sessions to sustain investments in key gap areas. And so what is new in this year's assembly? This is the 77th assembly. And so many of you would be wondering, what is new this year? What should we be on the lookout for? For the journalists who are joining us today, I can see we have teams from DevEx, BBC, we have local teams from East Africa, West Africa. I'm sure many of you are wondering, what are the hot off the press topics or resolutions in this year's WHA? If you're a public health practitioner like myself, you must be wondering, what new commitments will member states make? And are we working towards the SDG goals? Have we achieved our targets? Are we on track to achieve our targets? And if you are a private sector player, you may be wondering, are member states putting in stage a place where private sector can be engaged? Have we made headway when it comes to IHR negotiations? Is Africa on the journey of self-reliance when it comes to availability of essential medicines, commodities, countermeasures that will help us in times of pandemics? And if you are a techie, then you must be wondering 77 improving health systems and getting us better health outcomes. And if you're a global citizen who's joined into this pre-WHA press briefing, you're wondering, are we ready for the next pandemic? Are we on track as an African citizen? Where are we? And will these issues be discussed in the 77th World Health Assembly? Our speakers today are highly, highly revered and respected. They're stewards and thought leaders of the global health ecosystem, and they've dedicated their lives, their talent to solving and navigating Africa's health challenges. And today, they have the surmountable task of cluing us in and providing a peeping window into the upcoming World Health Assembly. This panel will share with us Africa's key health priorities, the associated investments, the impact that we should expect to see, the key resolutions that will be discussed on the floor in plenary sessions at the Assembly. And so I would like to then introduce you to our speakers, and I will read their bios, and then we'll get into a scene setting before we introduce them to make their remarks. One of our first speakers is Dr. Ngashi Ngongo. Dr. Ngashi Ngongo is the Chief of Staff and the head of the Executive Office of Africa Centers of Disease Control and Prevention, that's the AU. He will be stepping in for the Director General, Dr. Jean Kaseya. And Dr. Ngongo is a public health physician with 33 years of experience, both at national and international level. He currently serves as the Chief of Staff and the head of the Executive Office of ACDC. Before that, he served as a team leader of UNICEF Global Malaria Program in New York, as head of UNICEF PMCTC, heading also the pediatric HIV programs. And he also served as UNICEF Ebola Health Response Lead in Liberia and DRC. Dr. Ngongo has served in several international boards, and he is also a lecturer at the School of Public Health and University of Lubumbashi, DRC. And we welcome you, Dr. Ngongo. Our second speaker is familiar to all of you, Dr. Moeti from Botswana. Dr. Moeti is the first woman to be elected as a WHO Regional Director for Africa, a position she held since 2015. And under her leadership in WHO in Africa, has become more accountable, effective, and results-driven, with a strong emphasis on partnerships with various stakeholders, including philanthropic foundations, civil society, academia, and the youth. And Dr. Moeti has been instrumental in putting together and driving WHO's 13 general program of work, in focusing it towards universal health coverage, health security, and in leveraging innovations and digital health for improved health outcomes. Her tenure has seen significant progress in work in Africa, particularly also in working to ensure that we are certified free of the wild polio virus, and have been quick in times of emergency response. I can attest to that, having been part of the COVID team. Dr. Moeti, you really did steer the continent as we were navigating the COVID crisis. She's a medical practitioner, holds degrees in public health from the University of London, has received several honorary distinctions from the London School of Hygiene and Tropical Medicine and the University of Health and Allied Services in Ghana. And our last speaker, also very familiar with him, is Dr. Githinji Getahi. He joined AMREF Health Africa in 2015. He has worked in various positions within the health, media, and private sectors. And prior to joining AMREF, he served as a vice president and regional director for Africa at Smile Train International. And Dr. Githinji is renowned as a leader on both global and regional fronts, with notable achievements, including co-chairing the Global UHC 2030 movement, serving on the Commission of Africa's COVID-19 response, and formerly serving on the governing body of Africa CDC. Additionally, he serves on the board of Coalition of Epidemic Preparedness and Innovations, that is CEPI, and in the board of trustees of Safaricom Foundation. And he was recently appointed to the board for Food for Education Foundation. And he is a very vocal advocate, pro-poor universal health coverage, and leads thought leadership, the largest thought leadership convening on the African health agenda. And I do welcome my panelists. You'll soon be hearing from them as we get into our briefing today. And so, yes, I'm sure we're all aware, all 258 of us who are on call today, that the assembly is coming on in the next few days. But beyond it being a convening where public health practitioners, civil society, philanthropic foundations, development partners are all coming together, there needs to be a premise of why the world convenes every year. And one of the biggest calls of why the World Health Assembly exists is to be able to work with countries as they move towards universal health coverage. And so the big question would be, where are we as countries navigate and take different journeys on UHC? Now, last year in September, this is about 8 months ago, WHO and the World Bank jointly published the 2023 Universal Health Coverage Global Monitoring Report. And the report was alarming, colleagues. Essentially, the report told us that more than half of the world's population, that's 4.5 billion people, are still not covered by essential health services. The report went further to tell us that 2 billion people face severe financial hardship when paying out of pocket for services and products that they need. More alarming news, over the past 20 years, less than a third of countries have improved health service coverage or reduced catastrophic out-of-pocket spending. And if we all can look at our screens, you can see this is a publication right out of the report that shares with us the positioning of where we are as the globe. And you can see that countries are essentially on a decline when it comes to service coverage, and they're on a decline or stagnation when it comes to out-of-pocket expenditure. And so it means increasingly, the inequities and poor access to health services. The report also did tell us more than 1 billion, that is 14% of the global population, experienced large out-of-pocket payments relative to their budgets. These 1 billion people had to make choices as to whether to feed their families, to house their families, to clothe their families, or in essence, to access healthcare services. Now, were there improvements? Was there any positive news in that report? Yes, there was. And particularly between the year 2000 and 2015, sub-Saharan countries and countries in the African continent did improve in terms of UHC coverage. However, there was a stagnation after 2015. And what caused this improvement? The improvements were basically due to increase to ART coverage, HIV services. Now, what is sad about the report is if we look at 2015 to date, to where we are today, May 2024, there's been no significant change in service coverage. There's been no significant change in reducing out-of-pocket expenditure. And so this will definitely be one of the key conversations that will be taking place as we all head on to the 77th World Health Assembly. And my panelists today will be able to share with us in the spaces that they navigate, what do they see in terms of the African health agenda? What do they see in terms of key issues that need to be discussed and convened around in this year's World Health Assembly? Our panelists will be able to tell us, are we anywhere closer to reaching the 3 billion target? The 3 billion target, which is what member states all signed on to, essentially states that 1 more billion people should be able to access universal health coverage. 1 more billion people should be protected from emergencies, and 1 more billion people should enjoy better health. And if you jump into the 3 billion dashboard right now, you'll see we're all far off from reaching these targets. And so I'll be inviting our panelists to share their remarks, and later on we'll get questions from the audience. To start us off, I'll have Dr. Ngashi come in and share his remarks in 5 minutes. You're very welcome, Dr. Ngashi.
Thank you very much, Dr. Wangangi. On behalf of Africa CDC and His Excellency, Dr. Jean Cassel, the Director General, I would like to thank AMREF for inviting us to speak at this Pre-World Health Assembly press briefing. As Africa CDC, we are attending this year's assembly with expectations to see Africa's health priorities take center stage as articulated in the new public health order toward our vision of a safer, healthier, and prosperous Africa. We'd like to see really the discussion also focus on Africa's critical public health priorities linked to universal health coverage and also to health security, including recurrent vaccine-preventable disease outbreaks such as cholera, measles, polio, yellow fever, and diphtheria, emerging and re-emerging diseases such as mpox, the burden of endemic diseases such as malaria, HIV, and TB that still continue to pose significant challenges on the continent, antimicrobial resistance, non-communicable diseases that are approaching epidemic proportions in some settings, and there's still very high maternal and child mortality on the continent. Just to say that all this is happening in the context of weak health systems, conflict, insecurity, climate change, and other social determinants such as poverty and food security. And the situation is still of great concern. Just to give an example, that last year alone, we registered 166 public health events and outbreaks. Now, when you take an average of that, it tells you about 3 events every week. That's a huge challenge when you look at the context of Africa in terms of the systems and also the financing and the overall capacity to respond. Also important to say that we cannot overlook the profound influence of climate change on the continent, what we are seeing on the health outcomes across across Africa. Extreme weather events, environmental degradation are exacerbating the health risk and also affecting the most vulnerable communities. Now, to address these challenges, Africa CDC launched last year its second strategic plan for 2023-2027, which identify 7 strategic pillars, which include strengthening integrated health systems, in particular primary healthcare and also community health systems to accelerate disease and disease control and prevention. And second was to accelerate disease surveillance and epidemic intelligence for early detection of public health threats and disease outbreaks. Third was to strengthen the public health emergency prevention, preparedness, and response. Fourth was to strengthen public health institutions on the continent to better coordinate and support essential public health functions. Fifth, or to strengthen laboratory systems and networks to enhance diagnostic and pathogen genomic sequencing capacity. And finally, is to accelerate the agenda of local manufacturing of vaccines, therapeutics, and diagnostics, and other medical products as well that we're really pushing, leaning on the lessons of COVID-19 that Africa is trying to push toward its independence on medical products. Now, in this regard, we can mention a few of the Africa CDC's achievements that we've really worked together with our key partners at WHO, AMREF, that are with me here on the panel, that we work very, very closely. That Africa CDC, we have worked to establish the Continental Coordination Mechanism to lead the collective effort to realize the AU Head of State and Government resolution to recruit, train, and deploy 2 million community health workers as part of really strengthening primary healthcare system for the most vulnerable. We have launched the Continental Event-Based Surveillance for early detection of public health threats and disease outbreaks, very important. We have supported the establishment of a National Public Health Institute in at least 40 member states with strong public health emergency operation centers. We have also supported the strengthening of the laboratory capacity in 38 of the 55 member states on the continent that do now have pathogen genomic sequencing. Finally, you heard in February this year that through Africa CDC, the head of state took a resolution to establish the platform for harmonized health product manufacturing and also the pool procurement mechanism to allow member states to produce locally, but also to buy local products that are producing in Africa. Now, to finish, just want to say that this 77 World Health Assembly offers us an opportunity to also discuss the challenges that we are facing in those areas that are of critical importance to Africa, but also then leverage the partnerships, I think, that are here to be able to act jointly in a more harmonized way toward, in the spirit of one team, one plan, one budget, one M&E, so that we can really optimize the impact of our collective effort. Together, we can build a safer, healthy, and prosperous Africa that will help us to realize the goal of the Agenda 2063 of the Africa we want. Now, I'd like to thank you for your attention. Thank you.
Thank you, Dr. Gongo. Very, very important points and information that you've shared with us, and we will be coming back to you. And I would now like to invite Dr. Moeti, Regional Director, WHO Afro. Welcome, Dr. Moeti.
Thank you very much. Good afternoon, good morning, or good evening, depending on where our colleagues, the journalists, are. I'd like to thank you so much, Dr. Kitahi and AMREF Health Africa, and also say hello to Dr. Ngashi, and through him to the DG of the Africa CDC. I'm very happy to be joining this press conference and to join these prominent colleagues, friends, in informing the media and through you what is going to be happening at the World Health Assembly and what are some of the issues that are going to be being discussed. Thank you, first of all, to all the journalists for the work that you do on informing the public on health, and also on fighting misinformation on health, which has become progressively a significant problem. So the theme of this World Health Assembly is all for health and health for all. And I think it's a way of really underlining the fact that we are, and already Ngashi in his remarks has looked at the various stakeholders that need and do work together to produce health for everyone. So the fact that it is the business and affair and in needs investment in time and other ways of everyone, governments, partners, people, the private sector, and others, innovators, and it is health for all, meaning everyone, whatever is their status, wherever they are in the world, has a right to good health. So that's really what the theme is going to encompass. And we have a very heavy agenda in which all sorts of issues are going to be discussed. I'm hoping that our journalist colleagues are going online to see what is proposed in the program of the World Health Assembly. So it'll be chaired by the Minister of Health and Wellness of Botswana. So it's an African country that's going to be chairing the World Health Assembly this year. And as I said, very many topics will be discussed. I mean, I'll start not in the order in which you listed the issues, Mercy, but in saying that one of the topics of highest significance at this World Health Assembly, of course, will be how the world prepares for and responds to pandemics, based very much, I think, triggered by the experience of the COVID-19 pandemic. Even as we speak, not very far from where I'm sitting, I'm already in Geneva, there are negotiations going on. So member states have been engaged in negotiations for several weeks. These have had to be extended to this week in preparation for the discussions and hopefully the agreements on several aspects of how we prepare for and respond to pandemics in the future. So there's going to be the outcome of the working group on the amendments to the International Health Regulations 2005. So those have been the rules that have governed how we prepare together as a world, how we invest what we work in, and that have served as the means to assess where countries stand in their readiness to and capacity to respond to pandemics. And then there's also an intergovernmental negotiating body to draft and negotiate the WHO convention or agreement on pandemic prevention, preparedness, and response. And the Africa CDC and other parties, we have been working together in supporting these discussions. This is a member state negotiation, but of course, the Secretariat, WHO, and other interested parties have participated in providing the information required so that we look forward to an outcome that is based on the best information, best experience, and attempts at reaching agreement of our member states across the 200 plus countries, as you said, in very different circumstances. So our member states in the African region have been very much engaged in the working group and the INB negotiations, and our responsibility is to help them to ensure that the region's context and issues are sufficiently taken on board as these negotiations are concluded. We hope very much that an agreement is reached during this World Health Assembly or by the end of the World Health Assembly, and that countries find common ground. And we're very encouraged by what we have observed in the last few days in terms of the coming together of member states. I won't go into the various details, perhaps they will emerge in questions, but some of the big issues are around how to balance contribution of biological material by countries with the benefits then of the tools that are developed after those are used, and to have equity in access to the tools to deal with pandemics that were so starkly highlighted by what happened during the COVID pandemic. In addition to that, simply the looking at the need to, in terms of preparation, to build the capacity. So working with Africa CDC and others, we are very much engaged as WHO in supporting our member states to identify the technical capacities needed, train different types of people, including healthcare workers at different levels. We have a special initiative in WHO where we have trained for, I think now about 25 countries, a core group that is the group that is at readiness to be deployed to go and look and see what's going on, and to be the first group to start the response while the rest of the national system is responding. So we are very happy about this, because in the past, Africa is very much dependent on international support. So we've reckoned that it's necessary for each country to have a core group of trained multi-sectoral people to be the first group to respond, etc. We need to make sure as well that the supplies are poised to be delivered to countries. We've established a couple of hubs, one of which is in Nairobi and Dakar, and have put together the materials that are commonly required by countries. And we are able in 2 to 4 days to be able to start hitting the ground with some of the key materials and tools that countries need. Anyway, so just to say that the negotiations around pandemic preparedness and response are going to be one of the major discussions at the World Health Assembly this year. In addition to that, so there's not to be too long, of course, the Assembly will discuss progress and challenges, as you've said, towards universal health coverage. I agree very much that there's a lot more to do, but I'm very encouraged by the fact that we have seen some progress in Africa. For example, more people in the region can now access essential health services. We have a universal health coverage service coverage index that combines a number of indicators. And we see that the summary score out of 100 for Africa has increased from 23 in the year 2000 to 46. Now, of course, out of 100, that means there's still quite a long way to go, but it is going in the right direction. It's kind of leveled off, as you have said, and there are several factors to this. We also have seen that the proportion of people pushed into extreme poverty due to having to pay directly for healthcare costs has reduced since the year 2000. On average in Africa, it differs between countries, from 45% into the year 2000 to 14%. We do note that at the lowest levels in terms of poverty, there really needs to be work to be done. And of course, we know that we need prepayment schemes. Countries are working very hard to establish health insurance schemes so that households don't have to be paying directly out of pocket when there is illness. And there is a lot of work being done to share the experiences on the relatively small number of countries, I have to acknowledge, that have established and that have significant experience in this. And just to stress that African Heads of State, under the chairmanship of President Kagame, in 2019 launched a health financing initiative to close the funding gap and accelerate progress towards UHC. So in addition to providing technical support, policy support to member states, we advocate for leaders to continue to prioritize health in government budgets. We know that emerging from the COVID-19 pandemic, our countries are experiencing additional health challenges. And I've heard very often His Excellency the President of Kenya advocating for a fair system in terms of access to financing for development, including for health. I can only echo that and urge the international community to ensure that African countries can borrow affordably, so to speak, and have access to financing. You already said non-communicable disease will be discussed. Just to cite another, you can't go through the whole agenda. And the assumption is that Africa is a place where you get mainly communicable diseases. We are seeing a fast emerging, almost pandemic of non-communicable diseases, where we face a huge financial gap in financing to address these. So it requires really a more integrated way of working to use the resources that are available, including, I think that COVID drove this, because we saw that the people who were most vulnerable to getting severely ill from COVID were those that had non-communicable diseases. So that means we can't divide these types of diseases. We have to make the links, including in financing, to address those in a person-centered approach we are now promoting in WHO. And then other issues, of course, we'll look at maternal and child health mortality, which still is significant in Africa, even if we have seen a 44% decrease between the year 2000 and 2020. We still have far too many mothers and children dying in childbirth. We need to see why that is, what is the case. I'll just end by saying that among many other matters that will be concerned, climate change will be among the priorities. As you know, WHO organized at the COP28 a special day for health, and to underline the connection between health outcomes and climate change. And I'm very happy to say something like 19 member countries attended this. We now have to see how to place health on the mainstream agenda of climate change, and ensure that everything that we do working with other sectors helps prepare and respond in our health systems and beyond to the impact of climate change. So I'm looking forward very much to the World Health Assembly and to conversations with our colleagues from the media to see how together we can help the discussion, the dialogue among, as I said, many stakeholders who are important in health. Thank you.
Thank you. Thank you, Dr. Moeti. We have many questions rolling in for you, and so we'll be coming back to you shortly. I'd now like to invite Dr. Kithinji Kitahi, the GC of AMREF Health Africa. Kindly make your remarks.
Thank you very much, Mercy, Dr. Mopengi. And thank you to Moeti and Gashi. WHO, Afro, and Africa CDC have been great partners of ourselves, great partners for the continent in moving forward the agenda. So for us, we cannot have and discuss the Africa Health Agenda without Africa CDC and WHO. So we're really grateful that Ngashi, on behalf of DG Kasea and the Regional Director of WHO, Moeti, could join us. So thank you very much for that. Colleagues, we really appreciate it that you could join this press briefing. It's important for us to ensure that as we go to the World Health Assembly, that we understand what we are going there to do. You know, the World Health Assembly is my 9th one, actually. I don't know how many that Moeti has attended, having been Regional Director of WHO Afro. It's my 9th one, and you know, it's very busy, and even for those in the media, it's very busy, and it's very difficult for you to track what's happening where. So we thought it's important to hear from Africa CDC and WHO Afro to just say this is what's going to be happening. So if then the media is interested in particular areas, it's easier to navigate what's going on, and also to have the big picture, because otherwise you can attend small meetings and then you miss the big picture. So I thank both Moeti and Gashi for giving us the overview of what's going to be happening, and I hope that you'll track that. Now, on our side, you know, I look at the moment we are at as a moment of public crisis for the continent of Africa. The Africa Health Agenda, as I've said before, is actually a different subset of a global health agenda because of the vulnerabilities that have been discussed. Moeti has said only 46% of the people have access to health services as defined by the UHC index, the SEI, the service index. That means that 54% of people do not have access to the services. That is significant, and I'm sure we'll be discussing why so. And with that kind of vulnerability, we then have, you know, with that very low access to UHC, but even where it's increasing, as Dr. Moeti has mentioned, it is actually increasing at the expense of people's pockets. So when you look at GDP percentage expenditure for people in the poorest countries, in the low-income countries, the GDP, household GDP per capita expenditure on health is the highest in the low-income countries. It is lowest for high-income countries. So basically, the vulnerable are the ones that are actually carrying the health systems in their countries, which kind of multiplies the vulnerability. And I think we need to understand that. And within that crisis, therefore, that's saying we need to accelerate, and we have the urgency to accelerate the achievement of WHC, comes the climate crisis. And we are seeing now the climate crisis. I'm in Kenya now. We just had a devastating flooding incident, the worst in a very long time. We can't remember the last one like that. And out of that, we have almost 300 people or more who are dead. I'm told more than 1,000 pregnant women were involved in displacement in the 50,000 households that were displaced. We have, almost, I think it's more than 80 health facilities affected, roads disrupted, therefore access to even the facilities that are remaining is a challenge. We are now involved in efforts to vaccinate against cholera, and the challenge of availability of cholera vaccines to actually vaccinate everyone who is at risk, and all that coming from a climate crisis. And this is going to be repeated year in, year out. And you can look at that beyond the flooding. You can now look at what's going to come after this, other than cholera outbreaks, is malaria outbreaks in these areas, and also venomous snakes that are moving from places following the flooding that are going to affect communities that do not originally have venomous snakes. And then you're also going to end up with drought, and that drought is going to result in malnutrition and all these other things we're talking about. So on top of the vulnerability of only 46% with access, the 54% that have no access are also subject to the flooding and the climate crisis. In Kenya, more than 42 counties out of 47 were affected. So more than 90% of our populations were affected by flooding. But you can say, if you use the continental statistics, then you can say only 46% have health services. So people are being affected without access to health services. The next thing is that we have a youth that's rising, with more than 75% of our population being under 35 or 73, depending on where you are, but more than 50% below 19. But it is a youth with promise of demographic dividend, but without hope. So we are seeing that jobs are not being created fast enough. We are seeing that youth are also subject to this climate crisis. We are seeing that the hopelessness is going to increase because people have to fetch water further. Even now, as we speak about Kenya, and I'm just using Kenya as a case, even as schools opened, there were schools that could not open because they were already, the schools had been destroyed by water. So those young people, have hope, have a promise, but they're hopeless because as others learn, they can't go back to school. So that youth dimension is adding more issues and more vulnerability layers to an already difficult situation. And then we have the health security crisis that Gashi talks about, more outbreaks, and of course exacerbated by the climate crisis. And then we have regional conflicts that are happening. And where there's conflict, there's moving populations, there's displacement of people, and those displacements, just like in the conflict, in the climate crisis, are the ones that are likely to get further and further from health services. We know that zero-dose children are more likely to be found in fragile states, conflict states, where there is movement and displacement of people. Of course, we have celebrated progress, as Moeti has said. We have had major progress on child mortality and morbidity, the same for maternal. We've had decreased infectious diseases, significantly HIV, malaria, and TB. But we must recognize that during COVID, post-COVID, we've seen stagnation. So these are the challenges that are creating this public crisis. But of course, we must recognize also that there is actually a recession on civil society and sexual rights driven by states, by groups that are actually taking away the rights of adolescents to access reproductive health services, knowledge on sexual rights. So that also compounds the issue. And all these things are in a state where Africa's population is growing more than 2%. It is probably fastest growing in the world. And we are seeing Africa's population being more than 25% by 2050 of the world. So this is not an Africa problem. This is a global problem. So when we are talking about these issues, we are talking of Africa, not because Africa is special, but because Africa is the most vulnerable. And therefore, in terms of equity, the world must start with the most vulnerable because we are all as strong as our weakest link. But how do we move forward? We move forward through all the features that have been explained by Moeti and Gashi, talking about the Africa Health Strategy, 7-year strategy, the Africa Health Strategy 2030, which is also supported by the African Union. And that includes principles around respectful partnerships. partnerships that respect local knowledge, that knowledge of local people, that when flooding happens, people don't sit and wait for us to go help them. They have knowledge about who actually could have been affected by the flooding. Where are they? It is the communities that know who is displaced, communities that know who is missing, communities that know who is pregnant, communities that know who is living with disability, and therefore making decisions ahead of ourselves or any international local organization in terms of the response they need. So we must recognize and respect local knowledge, and that means we must align to country plans, country budgets, community needs, and also integration, that we are not only talking about one disease that has been lifted up because of health security. We know that COVID has been very important, but we must remember the people who suffer COVID are the people who have low access to antenatal care. They have low access to vaccination. They have low access to the early diagnosis for non-communicable diseases. And all these things, therefore, must be seen together rather than to over-focus on one particular disease. And this is why we saw that there was a bit of friction in DR Congo a few years ago in response to Ebola. And people are saying, what about the children dying of cholera yesterday, today, tomorrow? What about the children dying without vaccination? That must also, every life has equal value, whether it's dying of COVID or dying of cholera and dying of pneumonia, they have equal value. And the challenges of people having hypertension and not being able to access health services, because hypertension, diabetes, cancer are the ones that people actually disproportionately spend their money on, selling land. 80% of NCD care is funded by households, as opposed to non-communicable diseases that are covered largely by international development support. So all these things must be seen together. Health security is a health system access issue. So when we look at all these, AMREF and our partners, many of them, are looking at what is it we need to discuss at WHA, as has been discussed at WHA77, and we've convened partners to address many events that go around, for example, harnessing country learning and leadership in terms of localization. What should it look like? Looking at accelerating reduction of maternal and neonatal disease, looking at antimicrobial resistance, which was talked about by previous speakers, looking at the future of global health initiatives, what we call the Lusaka Agenda, which is about working with the global health initiatives, Global Fund and Gavi and others, to localize their strategies so that they are country-led, they are community-centered, they are people-centered. That will also be part of what we'll be discussing. Climate change and health financing, as has been discussed by Moeti, and also the areas around NCDs, but more importantly, also social participation for UHC, because the power rests with the people. We don't empower the people. We actually harness their power. How do we get the people to demand faster achievement for UHC? And of course, looking ahead to the G20 that is going to be held in Africa, and saying, what are the health priorities for the G20 in South Africa? So that we discuss that in advance, so that the G20 finds Africa prepared for the health priorities of this. And of course, also socializing this towards our Africa Health Agenda International Conference, which is going to be held in Kigali in March 2025. And you're all invited again for this. Many of you have attended before, and looking forward to coalescing and converging this agenda forward into the Africa Health Agenda International Conference in March 2025. So I would like to stop there, Marcy, because I know time is running out for questions, and hand over back to you. But thanks all for attending.
Thank you, Dr. Githinji. Now comes the fun part. There's a lot of excitement in the Q&A box, in the chat box. We have lots of questions for you, and so I will essentially share and pick different panel members to share your questions. Thank you all for joining. I can see journalists coming in from Malawi. I can see people from Tanzania, Kenya, Canada. I've seen somebody from Ivory Coast. Please be aware that we do have translation services available from English to French. And so the first question goes to you, Dr. Moeti. And if you look at the Q&A, a lot of interesting questions on the pandemic treaty, a lot of questions on how should Africa position itself. And we do appreciate that member states are at the forefront of this discussion. And if I could highlight one of the questions from Lizzie. Lizzie says, focus has shifted to the pandemic treaty. How do we shift this focus back to universal health coverage? Dr. Moeti. Dr. Moeti, I don't think we can hear you.
Yeah.
Perfect.
Thank you. That's an important question. I think actually that's a great way to emphasize the fact that there is a very strong connection between the matters that are being negotiated in the pandemic treaty and universal health coverage. I think you said it very well. Everything that's going to happen in terms of preparedness and readiness and response to pandemics is going to happen through the health system, including right down at the community level. So whatever it is that we are debating and countries are deciding upon and investing in terms of universal health coverage will really determine how soon can countries detect that something is about to happen. So how can we prepare in the different components, the human resources that need to be not only in specialized technical centers in the capital city, but right down at the community level in the most remote places where you need to have people who are there able to detect, to be prepared to detect when something is happening which is not normal, and who need to be aware of, if you like, the rules, how to act, that are part of what is being discussed in the pandemic treaty. One of the most, and I have to say in the last few days, there has been great progress in finding agreement between different types of countries, between developed and developing countries, for example, around some aspects of the pandemic treaty. If we look at the issue of pathogen access and benefit sharing, which is continues to be one of difficulties, where do you obtain the specimens that are going to then be used in terms of developing tools? These are from people. And not only from people sitting in capital cities, from people who may be people at the lowest level in the country, in the most peripheral level. So for me, these two aspects of global health are very strongly connected. And I think it is very good if that is realized, that even if you're in the most remote village, you're a low-income person, your contribution to the ability of your country to detect, to be prepared for, as Githinji was saying, engage in communities and respond to a pandemic is very, very important. If there needs to be vaccination carried out, communities need to be part of it. Community health workers, those health workers who carry our health systems in the peripheral areas, right up to the central hospitals and the specialized agencies, all need to be involved. So I would say there is a very strong connection, and the pandemic preparedness and some of the negotiations that are going on, for example, about local production of tools, those are based on having scientists who are doing research using the national systems in our countries, which needs to be through our health systems. So I really think that the strong connection is there. We need to emphasize and recognize it so that we can also be efficient in where we are investing the resources that are supposed to make the different parts of a pandemic treaty that is fair and that builds the capacities in countries, and a health system that is able to deliver universal health coverage. So I think they're very much connected.
So Dr. Moeti, you say they're connected. You say we should continue investing in the treaty discussions. Dr. Ngongo, a very cheeky question here. Why are we taking so long? Why are African member states seemingly divided? And what are you doing at the Africa CDC to bring us together, to have an African voice? And you're on mute. You're on mute. I hope you're not on mute on purpose, Dr. Ngongo. This is a tricky question.
No, thank you very much, Mercy. I think a very interesting question. We know that I think the problem we had is that I think we had our own challenge in ensuring that as Africans, we speak from a common voice. I think that was the first challenge, to make sure that among ourselves, we have a common position. And then when we go into the negotiations, we are also speaking with a common voice. And a lot has improved, I think, in that direction. the Africa CDC had to travel a team to Geneva. They had to make sure that we sit over our negotiators, the ambassadors, and really understand where the misunderstanding and know where to be able to address some of the challenges around those 4 areas. I think Dr. Moeti has already mentioned the PABS, which was this benefit sharing, which was a critical issue. There was also the issue of the One Health, the issue of financing, and the issue of intellectual property. I think those are the 4 issues that were really very difficult for us. But progress has been made. As you saw after that, we also convened a meeting here in Addis in April with all the 55 members were invited here. We had at least 32 ministers that came here, putting the ministers together with the ambassadors this time. And there was some consensus. I think we are cautiously optimistic, if I can say so, that with the negotiations going on, of all the discussions that we've had already to harmonize our views on those 4 points, we might get an agreement signed at the end of the assembly.
Oh, this assembly. So journalists should be watching out for this 77th assembly. Let us exercise cautious optimism. Dr. Githinji, I see a question that says that CSOs and NGOs have been isolated from the INB discussions. Does this matter? Does this spell a new future for CSOs? And what can we do to ensure that this voice is not lost in these discussions?
Wow, a very difficult question. And I think it's this question has been there for many, not only for this WHA, but also for UN General Assembly. We are negotiating major documents. I think the involvement and engagement of CSO, and maybe I would like to also request Moeti to comment on this, is something that goes on for long, and especially when you have member state negotiating frameworks. Member state negotiating frameworks mean that the member states tend to want to have views of CSOs before, and then after that, take over the process and the conclusion without making reference to CSO. We've seen this in most cases. In the INB, I've seen several briefs for CSOs, actually, which was originally there was a lot of resistance. Then I saw briefings for CSOs who are invited to be briefed on where we are and what's going on. But in actual negotiation process, the member states take that on themselves because they're the ones eventually that actually make the decision. And I think because this is something I personally have been involved in fighting for at the UN General Assembly when we are doing the AC declaration and moving forward. And looks like the member state negotiating processes haven't found a proper mechanism, other than the multi-stakeholder hearings, the input submissions, haven't found a proper way of having CSOs, and not only CSOs, other sectors involved in actual negotiations. And I think that this is really a calling for CSOs, because civil society organizations ideally should derive their power from the people. It is, we need to have a very clear distinction between international organizations and community-based CSOs that actually represent certain sectors and communities and what I call constituencies back at home at the national level. And I think we need to start having a very clear focus at the national level. Even as we maintain our international level, we must have a clear focus on the national level. What am I saying? I'm saying that the participation of CSOs can also be a powerful tool to force governments to take positions before they go and negotiate as a member state. Back home, I would want to hear an example of CSOs in a country that actually went to their parliament and demanded that governments who are negotiating as member states take a particular position. When we are discussing, for example, this issue that Moeti talked about of pathogen access and benefit sharing, which sometimes I like to cheekily call profit access and benefit sharing, because actually that is really what puts the border. So the kind of acronym is the same. You can call, this is a very strange phenomenon because the pushback is from the countries from where the pharmaceutical manufacturers are, not where they are supposed to, they will eventually be as we're looking at the African manufacturing agenda. If we have countries where civil society have gone to their parliaments and said, Parliament, we want you to pass this as a position, of this country when they go to negotiate. That will be the more powerful civil society engagement, which is country-born, because the member states then have their hands tied by the civil society and the legislative systems back in their countries. This is the future I look forward to. But that doesn't mean there is no role for CSOs in the multi-stakeholder hearing, in the negotiation process, and a pathway needs to be found for that. But I'm calling upon all of us to actually wear our gloves and boots and force the hand of government at country level on the position to negotiate.
Thank you. Thank you, Dr. Githinji. Now, Dr. Moeti, Dr. Githinji has asked you to make a comment on the role of CSOs, and I'm looking at the questions, and I'd want you to also tackle one question that has come from Dr. Daniela from IFRC, who says, as we discuss pandemic preparedness, is there a position on risk communication and community engagement? And somebody else then asks, how far are we with the WHO emergency framework? Are countries really consolidating around it? So over to you, Dr. Moeti. And Dr. Ngongo, I'll be coming to you very soon on African manufacturing. Dr. Moeti?
Yeah, thanks. I think, first of all, on the role of CSOs representing people in these negotiations. I mean, I think the situation is improving. As far as I'm concerned, as far as I'm informed by my team, there have been some briefings organized for CSOs around where we are with the negotiations, presumably getting their input as well. I do agree that this could be improved, particularly at the country level, so that because the discussions that have happened at the country level have included not only the ministries of health, there are other sectors that are very important in the discussions around pandemic preparedness. And some of the countries have engaged the other sectors. Of course, we have to engage the finance sector very much, and because this is part of the agenda is to obtain the resources that are needed to improve the preparedness in countries. So I think this is a work in progress that is improving. That could perhaps be made more structured, particularly at the country level. And what I can say is that as WHO, working at the country level with our member states, we will encourage that to happen, that there can be fora where people can, and organized community organizations can come and provide their input. I mean, we've had very good lessons learned from one pandemic that's still going on, the HIV pandemic, in the role of civil society, the role of organized community groups in influencing national policies, right up to influencing the decisions that are made at the Global Fund. So I think that experience is something that can be taken on board and used to inform the current negotiations that are going on. And we will certainly support it in the African region. I think risk communication and communication on emergencies, we are continuing during the pandemic. We established through our very small communications team, but working with our communications, some partners and some media, risk communication and infodemic process, whereby we organized by looking at scanning the information and the misinformation that's circulating around, and then finding ways to package the right information and get it through partners so that people have the right information, the media organizations have and disseminate the correct information to people. And I think that communicating around the pandemic is something that we can engage upon, building on that experience. Of course, the IFRC has been a great and very important partner in engaging communities and passing information on to them, and as well engaging in getting information from the community level to the decision makers, which is an equally important role, so that their views are taken into account. So I appreciate that very much, that question. The WHO emergency framework has just been adopted. So it's a framework that guides how WHO and member states are going to be working on dealing with emergencies, really reinforcing based on the lessons learned, including from COVID-19 pandemic, the types of investments that need to be made in different aspects, human resources, ensuring that the data systems are there. We use technology in order to collect and share data, and ensuring that data informs action in a much faster way. And then connecting with the health systems, looking at some of ensuring that we are prepared for the most common items in terms of supplies that are required for preparedness and to be able to engage in rapid response. And then some of the tools, including thinking about vaccines that are needed, how to prepare for making those available and developing tools quickly. So it's being finalized and agreed, and now will be discussed with member states and stakeholders, the emergency framework.
Thank you. Thank you, Dr. Moeti. We only have about 10 minutes to go, so now I'll do a rapid fire session. So Dr. Ngongo, Kenya is grappling with a shortage of life-saving childhood vaccines. This means that 1.6 million infants are at risk. And I can see another question on cholera vaccination. What is the Africa CDC doing to support the Africa manufacturing agenda? We heard during the COVID-19 pandemic that there were supply chain bottlenecks. Have we fixed them? Are we fixing them? What are we doing?
Yes, thank you very much, Messi. Yeah, I think in the area of vaccine manufacturing on the continent, the partnership around African vaccine manufacturing, which during the recent AU assembly was then broadened to include also diagnostics and therapeutics. But on the vaccine manufacturing in particular, we've just completed the landscape analysis of vaccine manufacturing capacity on the continent. Together in collaboration with CHAI and PATH. What we observed is that there are about 30 manufacturing plants in Africa right now, 9 that do have adequate capacity for production, of which 3, unfortunately, 3 only have the capacity to produce vaccines in the short term. That's 3 to 5 years. Not enough, but it is a good start. And the vaccine they can produce are the 8 vaccines that are the most used for routine vaccination. But also the good news is we have also some of the vaccines that are used in emergencies, like cholera vaccine that we're just talking about at the beginning. And that is the first thing that we wanted to. It's just to understand what capacity is there on the continent. But at the same time, we've also worked on the financing of those of the local manufacturers in Africa. As you know, there are these really challenges of financing which are huge. You heard about the launch of the African Vaccine Manufacturing Accelerator with Gavi. I think that we worked very hard. I think all of us with WHO and Africa CDC really pushing that. That is already a very good accelerator. It's $1 billion that is being invested to support the African manufacturers over the next 10 years. And at the same time, though, this challenge that has always been there, that even if you produce the vaccines, if there is no market for the Africans to buy African products, all those efforts will be just nullified at the end. That's the reason why we have now pushed this pooled procurement mechanism that was adopted by the head of state that will allow us then to pool all the needs of the different countries and then create quite the market for those local manufacturers. And in addition to that, we are working with WHO. I think we had a meeting, both co-convened by WHO and Africa CDC to discuss the whole issue of regulation, especially the pre-qualification. There is a really work that is also going on there to ensure that the process of pre-qualification that has been a huge challenge on the continent is also addressed. And we're also working locally on the continent, on one side, to see how the AMA process can be accelerated, and also in the meantime, how we can strengthen the national regulatory authorities of countries and the 5 regional ones to start the registration of those vaccines once they are put on the market. As it's just to say, it's an area that is moving. The challenges of vaccine production is the time that it takes. But right now, it is clear that in the next 3 to 5 years, we'll see some of the manufacturers, especially those three, starting to produce on the continent.
Thank you. Thank you, Dr. Ngongo. Dr. Githinji,
And
we
then
have
the
several
question that you
questions.
mentioned.
Okay. Go ahead.
No,
Go
so
ahead, Dr.
yes,
Ngongo.
I just,
yes,
if
just
I
wanted
may-
to say, wait on the point you raised about the supply chain no, in Africa, which is
Yes.
a huge challenge. You know what happened during COVID-19? There were two main issues. It is really supply at the last mile, which is very, very difficult because in some countries there are no roads and so on. You have to find all these innovations that we feed the drones and so on. That's an area that remains really entire. It requires a lot of work. That's also why we see the role of civil society really contributing, those that are reaching those areas to work together, with the government to make sure that we can reach the most vulnerable. The second key issue is some of these products also bring new challenges. They require new capacity equipment that never existed before. You saw that COVID required cold chain of very extremely low temperature, around -90 to -60, that never existed before. And you can see the challenge of putting those that kind of infrastructure in the context where the energy itself is a huge challenge. I think that remains a challenge. That's the reason why we are also working, on that area to make sure that we find the most simplified and adapted really equipment, and also the distribution system that is adapted to the context of Africa. It's also work in progress.
Thank you. Dr. Moisi?
Yes, thank you. Sorry to interrupt. I just wanted to add something on pool procurement and emphasize the importance really of doing a mapping of the conditions and the regulations of different countries to enable a pool procurement. We've had different attempts at pool procurement at the sub-regional level in African countries, and it has been a real challenge. We've just, as WHO, managed something fairly small with the small island states who mainly need medicines for non-communicable diseases, which are expensive. And okay, it was during COVID, but it took several years to get to harmonizing their rules for doing different things in terms of standards, how they carry out payment, how they do approvals. So I can only say that we have some lessons that we've learned in WHO supporting pool procurement. We've also been working for quite a few years to support SADC to carry out pool procurement. I mean, just to say that the investment in harmonization needs to be recognized from the very beginning. And if we're going to do pool procurement on a continental level, it's very, very important to recognize and invest in the process and the capacities to facilitate these agreements so that this actually does work. It's just a bit of advice from our own experience, and WHO is ready to be a partner in sharing the experience and the capacities that we have to support the African Medicines Agency and the pool procurement that is planned. Thank you.
Thank you. Thank you, Dr. Moiti, for that very important interjection. Dr. Githinji, we have several questions featuring on immunization. We have a question from Dennis where he says Kenya is lacking polio vaccines. We have a question from Sarah in Malawi who says we are struggling with cholera. Is AMREF working in this space to improve vaccine access to our children and in times of epidemics like cholera?
Yeah, thank you very much. And I appreciate the remarks that have been made earlier by Moiti and Gashi about the Africa manufacturing, pool procurement, sustainability of health commodities and technologies, because the questions that are being asked have to do with that, actually. When you look at the Kenya case is that the Global Vaccine Alliance provides vaccines to Kenya like it does to many other countries, but countries are required to make their own what we call counterpart investment in terms of financial investment to ensure they have the adequate volumes. And often when governments have competing priorities and, well, I would say probably not 100% political will on some of the areas, then you may end up with, with failure to budget for counterpart financing. And what that means is that the vaccines that are supposed to be bought from the country's own contribution or fiscal space will then end up with a shortage, because this whole entire plan of volumes is based on the cohort of births in a country. So it's well mapped. So if there is a financial gap, then you may end up with out of stock. And that's the situation that's going on in Kenya. The question is, what do we do when countries are in crisis? Debt crisis is going to be a big one across the continent. So I do not think that the Kenya case is isolated. I actually think that other countries in Africa, as the debt crisis becomes bigger and bigger as it is now, with countries using almost 67% of their revenues paying for debt, this problem that you see in Kenya is going to be replicated elsewhere. We just need to think about it ahead and avoid the crisis. On the other side, there are vaccines that are not necessarily on the Global Vaccine Alliance, like cholera vaccines. They are, because we have areas of policy decision-making in terms of cholera vaccines going to be onboarded to Gavi, because governments and WHO and others have then decided that there is a preventative role of cholera vaccine, and therefore they're given. And how do you model the at-risk populations? And because of lack of this policy framework, we don't have adequate volumes of cholera vaccines. So you have to import them for crisis. You have to import them for emergency. If we had local production, then the responsiveness of the country programs to vaccinate people when there is a crisis of cholera, because maybe there was flooding or there was a failure in the sanitation system, then we'll be faster. So that conversation we are having now on cholera vaccines, polio, and the others is also linked to sustainability, affordability, and that's why Ngashi is saying we need to build our local production. We need to bring down the cost of production by pooling. Many of you will know, Africa is 54 countries, so there are 54 markets. So there's no African market, as it were. It doesn't exist. What exists are markets in Africa, no African market. That means that we must, even as we do pool procurement, as Moeti says, we must also provide an enabling regulatory environment that says your commodity produced in the BioNTech plant in Rwanda, it's going to be available at the click of a button to all countries. So that is one market. You must open the barriers. And that's the importance of the macro issue of the Africa Free Common Trade Area, which is an Africa Union agenda. So the Africa CDC agenda is linked to the Africa Common Free or Common Market agenda is linked to the NEPAD agenda. So all these things are linked, and we must address them holistically moving forward. So what is AMREF doing? Yes, we are working with the policymakers, with Africa CDC. We contribute to the conversation at WHO, but also we work with governments. In Malawi, we've been involved in providing financial support to purchase and support communities through the government. For Kenya, we are involved in the conversation because we actually work closely with the Kenya government. We're involved in the conversation of accelerating the budgeting to ensure that this counterpart financing is provided for. Dr. Masi has been involved and a larger team in this work. So yes, we are involved where we can. We contribute, and where we can, we contribute through technical working groups and of course advocacy and policy work that we work with governments. I did mention that AMREF also hosts what we call the Africa Health Policy Leaders Forum, which is a forum of ministers of health. So some of these we address when we meet ministers together. We met, Moeti has attended this, Kasea has attended this. We have one also being hosted at Africa Cities, at WHA77. We get ministers together, discuss this challenge, and you might find when they get together, they're able to resolve some of these issues that may seem like country problems, but they're actually regional and continental problems. So that is also another way that we are helping. Thank you, and back to you, Mas.
Thank you. Thank you, Dr. Githinji. So we are now about to wrap up, and I do take note of all the questions that are in the chat box. I see questions on the role of data and technology. I see questions on financing models. I see questions on UHC. I see questions on emergency care systems. I see questions on human resources. Are we investing in HR? And what we will do, just because of time, is we will combine all these questions and we will share back responses with you journalists and members of the public who are asking questions. I see one jumping up in terms of surgical systems and the capacities we have for anesthesia and safe surgery when it comes to obstetric care. And so keep them coming. We will be able to respond to them by way of press release. However, the devil's advocate in me has one last cheeky question. And this question is a question that's coming in from Lucia Blanco, who is coming in from Spain's international news agency. And Lucia asks, are you as panelists, are you Dr. Ngongo, Dr. Githinji, Dr. Moeti, are you worried about the impact of the increasing anti-LGBTI policies in several African countries? Does this and will this affect the right to health of their citizens? Would anyone like to make a comment on that?
Yeah.
Dr. Gongo, would you like to come in?
Yes,
I can also
Miss.
come in.
Yeah, I
Yeah.
think Stenji, you can go ahead.
No, Gongo, go ahead. I'm happy to comment. Would you like me to go or you'll comment?
No, you can go ahead.
I told you it was a cheeky question.
This is a tricky question. Let's put it this way, that what we are seeing with the LGBTQI and the pushback is actually a bigger rights issue. It's a bigger pushback on adolescent health, the bigger pushback on sexual rights. We are seeing that even where countries have made progress on sexual rights for adolescents, there are signals that countries are pushing back on this because of many factors, including political alignment, religious groups that have different opinions. So this issue of LGBTQI is actually a larger issue of people's rights being taken away generally. Specifically on this issue, yes, of course, because when you actually criminalize a particular group, what you do is that you actually then make them invisible. You make their data invisible, which makes it very difficult for us to provide services. We know that a rights-based approach to UHC, rights-based approach to health services means everybody everywhere, irrespective of who they are, where they are, what their opinions are, must have access equally to everyone else on health services, including equity, including a purposeful effort to reach the most unreached. So when you criminalize groups, then you take away their right to access health services equally to others, and you take away their right to equity as well, because you hide them and you make them invisible. This is the risk. And we know, of course, that when there's a risk like this, you may have certain disease risks that are consolidated in groups. We know that especially there's a key population concern on HIV and TB, and this doesn't only affect LGBTQI groups, it also affects drug pushers and drug users, or drug abusers or drug users as well. So when you criminalize groups, then the impact is that they are not able to receive health services. What that means is that then you increase the pool of reinfection. And what that means is that actually you risk losing gains that you have made on these diseases. So it's actually a big health issue, is what I would say. And we must fight against it locally, regionally, and internationally.
Thank you. Thank you, Dr. Githinji. Dr. Ngongo, Dr. Moeti?
Yes, I mean, just to add, to say that these groups, LGBTQI people, exist in our families, exist in our communities, exist in our churches, exist in our schools. They are part of our society. I think that making that acknowledgement and acknowledging that, like everybody else, like all of us, who may be in these groups but not be self-identifying, by the way, because our societies are built in certain ways, have the right to access to healthcare. I mean, I sometimes think that apart from the move to make them illegal, the language in which this is discussed at the global level also needs to consider the context of different countries and societies. Because what I've observed is that in some cases, as soon as certain words that are recognizable get said, then you get a kind of instinctive knee-jerk pushback from certain types of countries. But we all know that these, we have people living different lifestyles in all our communities, in all our families, and all of us have the right to healthcare. This is what I would say, and would encourage that this be a principle that drives what gets done in countries, even if culturally, in the way that we behave socially, we speak socially, this may be difficult. And we work on finding ways on getting to this acknowledgement and this acceptance, and therefore providing for the needs and acknowledging the rights of these groups of people, really.
Thank you. Thank you, Dr. Moeti. Dr. Ngongo, you could give us your response and your closing remark.
Yes, I think just to support what both Dr. Gitenji and Dr. Moeti have said, health remains a right for every citizen of this continent. And when we talk about equity, we talk about equity for all. And therefore, I fully support what was said. In conclusion, I think I would just say that Africa is a continent of special challenges, but at the same time, a continent where also there are very good opportunities that we need to leverage. We have seen a lot of very encouraging progress. We are also aware of our challenges. Now, as we move forward, it is clear that unlike any other continent, we can only achieve if we work together. We can only achieve if we really apply a systems approach to what we are doing. Take every opportunity that we have, whether it is the health security on the emerging side or the universal health coverage, to build a resilient system that can serve both agendas. Because for us to achieve universal health coverage, for us to achieve health security, we need a system that is strong, that is equitable, that can really perform to the level that we expect. And on the continent, it is possible. I think we have seen those systems on the continent. Now, the most important for us is that we need also to be actively involved. That's why I fully agree with the point that Gitenji made about the civil society. We need all our layers of our society to be involved in the search for solutions that are adapted to the context. And secondly, we also need to make sure that those that come to support us, like this discussion around the Lusaka agenda, are aligned with our agendas and are aligned with our integrated approach that is critical for us to move this public health agenda on the continent.
Thank you. Thank you, Dr. Ngongo. Dr. Moeti, your closing remarks?
I think my closing remarks very much echo what Dr. Ngashi just said. Africa is a diverse continent as well. We need to recognize that. Sometimes when we speak about Africa at a global level, it sounds as if we're talking about a village. The countries are diverse. And in this diversity, in my view, lies a richness of capacity that we need to leverage from the different perspectives for improving the health of African people. Africa is young. One of the biggest opportunities that we have that's emerging now is technology. So we didn't speak much about technology, but with our young population who are connected internationally, who are using technology, I believe that national investment in technology, together with our partners, is going to unleash the capacity of our young population, not only for health, but also for economic development in Africa. This is one of the ways in which our young people are going to be able to innovate. We developed an initiative on innovation several years ago in WHO Afro. You cannot imagine the number of innovations that emerged. We supported some of them to find financing. And I believe that we can have innovative young people, scientists, who can not only contribute to development, but also to income, have a business, earn a living, and stop our young people migrating and drowning in the seas that they're trying to cross to go to other continents, but really develop this continent. So I believe diversity, young population, connected to innovation, connected to technology, and can really, and the current strong togetherness at the political level on the continent, as far as health and development is concerned, put us in a very exciting place at the moment. And we need to leverage this. And in WHO, we are very ready to support our member states to do this.
Thank you. Thank you, Dr. Moeti. Dr. Githinji, your closing remarks?
Well, I want to thank you, Mercy, for being such a great moderator. And thank Moeti and Gashi for responding to your very cheeky questions as well, and the difficult question from those who attended. It's actually been a really great engagement, and the questions themselves tell us what's going on. So the questions themselves tell a story as they are. So I think for me, the most important thing is to ensure that as we move forward, as we do pandemic financing, the pandemic treaties, as we do plans and strategies for climate change and health, as we do plans for NCDs, and as we do plans for communicable disease, maternal and child health, that we put the community at the center. Not because we are going to help them, but because the communities will help us achieve our goals. That is a community that has the knowledge. It is a community that's a producer of health, not just a consumer of it. It is the community and the households who are actually our goals of maintaining a healthy population in Africa, not building a biomedical system that is actually going to be based on providing care through healthcare, because it's unaffordable. As I will say in my closing remarks, in Africa, there are countries that spend $6 per person per year, and the highest country is spending about $350 per person per year. That is of public money. That is what they are providing for. Only 2 countries have made their Abuja declaration. That's Cabo Verde and South Africa. Only 1 country has made 5% of GDP to invest in health. And even when countries achieve 15% like they have, they still will not get anywhere close to the $4,000 that countries in Europe and $5,000 per capita that the US spends. So we cannot afford to throw money at the health problem, but we can afford to throw our knowledge at health by creating health so that we avoid the healthcare costs. Those are my closing remarks. I look forward to seeing all of you at WHA in Geneva, and I look forward to seeing all of you and more at the Africa Health Agenda International Conference, AHIC, in March 2025, 5th to 8th in Kigali. Thank you very much for joining, and for the organizers. Thank you very much. And for Moeti, WHO Afro, Africa CDC, thank you for the partnership.
See you soon. Bye.
Thank you. Thank you. Thank you, everyone, for joining us. And thank you to all the journalists who stayed on to the end. And thank you all to everyone. This will be shared. Our recording will be shared. I do invite you to also get into the strategic roundtables that will be taking place at the 77th Assembly. And these will also be webcast. And so thank you to everyone, and welcome to AHIC next year in Kigali. Thank you, everyone. Goodbye.
Thank you.
Bye.
Thank you.